And it gives me great pleasure to introduce Professor Paul Bennett and Thrombosis UK's fundraiser, Clare Prince, who are going to be talking about managing anxiety after the diagnosis of a blood clot. If you have any questions, please do feel free to put them into the Q&A section. And after Paul and Claire have presented and chatted about this, we will do our best to take as many of those questions as possible. You can also use the chat facility, which I can see some of you already done, to say hello to each other and to message or make comment. But if the questions can go in the Q&A, any resources that Paul or Claire may refer to, we will try and put links in to the chat as well, and would be available on the Thrombosis UK website. So without further delay, I will pass over to Professor Paul Bennett. Thank you.
Hello, thank you, Jo, and welcome from Mallorca. That Jo Jerome is such a hard driver of me that she's made me even do this on my holiday. So, but seriously, it's a pleasure to be here, and I hope you find something of interest and useful. What I'm going to do is kick off with a sort of spiel about anxiety, in particular related to various thromboses, and Claire, as our resident expert on sort of managing thromboses in general and also managing some of the emotional consequences, will sort of chip in and add stuff. And yeah, hopefully we can answer questions perhaps as we go through. It depends if they're relevant, but certainly towards the end. So here goes. So off we go. I think obviously the title of this is Managing Fear and Anxiety, and sometimes people genuinely experience fear, because one of the things that, as a psychologist, one of the things that drew me to working with people with thrombosis, and indeed doing some research, is that thrombosis is one of those health challenges that is almost by definition a difficult emotional event to deal with. It's sudden, it's unexpected, and people can often feel very scared as a consequence. And to add to that, many people find it difficult to get the immediate treatment, and the experience in A&E can be quite challenging for some people. And all those things combine to make the experience and the aftermath of a thrombosis potentially quite difficult to cope with. And the research that we've done, so this isn't just me top of an envelope, the research we've done suggests that about 60 to 70% of people experience significant health anxiety as a consequence and in the months following the experience of a clot. So if that's you, you're in the majority. It's almost a normal reaction to a very abnormal and quite scary sort of process. And often people talk about this being a mental health issue. I don't think of it as a mental health issue. I think anxiety following a clot or whatever is actually a normal reaction. But there are ways that we can help people manage that. We can speed up the recovery, which will happen in time. And that's really what I'm going to talk about now. And I'm going to do an overview of two different types of anxiety, if you like, that people experience. And each of the things that I'm going to talk about, there are some leaflets, some of them more or less detailed on the thrombosis website. And I can see that Jo is putting them on the chat now. So if people want to access those, they basically cover what I'm covering, but probably slightly more coherently and sensibly. So let's go for it. So I said that there were two different sort of experiences of anxiety that people have. And the first of those, I'm going to call worry. And a lot of people experience intrusive worries about their health, often for quite some time after they've had a clot. Am I going to have another one? What's going on? Oh, I've got a strange sensation. Is this another clot? What's happening? What about my health? What about my finance? What about my future, etc.? So there's a lot of reason that people need to think and need to sort of consider the consequence of having had a clot. But if that becomes problematic, if it becomes intrusive, so that every time people are sitting down, the worries come, or if you go to sleep and as you're going to sleep and you're drifting off, the worries are coming into your head and just going round and round. Well, that in itself becomes a problem because it's sort of adding to your distress more than sort of helping you moderate that distress. So Lisa's asked, can CBT help? Well, what I'm talking about is actually parts of CBT. CBT is a sort of broad set of interventions that there's a lot of evidence out there that it can be very helpful. There's also some CBT came along in the 1960s, 1970s, 1980s, and how people define it now can be a little confusing, but things like mindfulness, which I'm going to talk a little bit about if I remember, are probably newer than CBT, and they can also be useful. But the basics of CBT are quite interesting. But I'm actually going to I will talk about where CBT and some of these newer approaches, mindfulness, and may differ quite markedly. And actually, I think the newer methods are actually probably, if I'm honest, a better way of dealing with it. And one of those is about how we manage worry. So let's talk about worry and how to manage it. The problem with worry is that we are all designed to worry. If we don't worry about things, we don't get motivated to deal with things. If you're worried about, the money coming into the house, you get a job. If you're a student and you're worried about your exams, you revise. Worry makes us do things. It motivates us to sort of manage the problems that we're experiencing. The problem is that there are two types of worry in a way. There's worry that can lead to a solution. So what am I going to say next time I see my hematologist? What questions do I want to ask? I want to think about medication change, etc. Those are sort of, you can think through and you can come to a resolution and you can come to some sort of, the worry stops because you've dealt with it. But a lot of this worry that people have following a clot and other health problems, to be fair, is a sort of more amorphous. What's going to happen to me? What's that sensation? And they often don't lead to a conclusion and just go round and round and actually become much more problematic. So part of the challenge of managing worry is not to stop thinking about issues, but to try and manage when you think about those issues. So at the moment, if you're sort of overwhelmed by worry, worry is driving you, it's controlling you, and it's controlling your emotions. And what is the trick is to sort of almost flip that over and you to decide when you're going to worry, when you're going to think about things, and then at all other times to learn to disengage from those worries, to get out of that habit. And I'm going to call it a habit because worry is very much a habit. It's triggered by things. It's triggered by going to bed because you begin to think about things. You see something on the TV, you have a sensation that triggers those sorts of worries, and that worry can become habitual. And by calling it habitual, what I'm not saying is it's trivial. It's a very powerful, very problematic habit, but nevertheless, it is a habit. And part of managing worry is to try and break that habit. So there's two elements to sort of managing worry, as I say. The first is to actually put a worry time back, and then at all other times to learn to disengage from those worries. So I'm going to talk about why you have the worry time and what it is, and then look at some strategies for disengaging. So the idea of worry time is that, it's useful to think. As I've said before, some things we need to think about, some things are important to consider. So, you can't just say, I'm not going to think about that. It's not an issue. I'm going to disregard it because important things won't be going through, won't be dealt with. And sometimes even those emotional, those things that are a bit more amorphous, we need time to sort of process and think about, what is life going to be like? How am I going to manage? What about this? What about that? So, both for those problem-focused worries, as I will call them, and some of those other more amorphous worries, it's still useful to find time to think about them. But the goal, the process is identifying a time of your choosing and to think about them for a predetermined time, maybe a quarter of an hour, maybe 20 minutes, and then to move on, to disengage from them, because there'll always be tomorrow and tomorrow where you can think about them. So it's not that, so this isn't about disregarding the content of those worries. It's about controlling the time when you deal with that content. At all other times, it's about disengaging from those worries. And coming back to Lisa, one of the things that classic CBT would do, in some ways, oddly, would get you to focus on the worries. And so, you might have a worry of, oh, is my health going to be all right? What's going to happen about X, Y, Z? And then classic CBT would say what you need to do is to think more positively about those things, to challenge, things could, there's no reason to assume I can't recover. There's no reason to assume that I'm going to be, have problematic health issues and so on and so forth. So you get these negative thoughts and then you would challenge them with more positive thoughts. And that is classic CBT. But I think nowadays we're sort of moving on. And the idea is that it is better to try and to disengage from those thoughts rather than to try and challenge them. Because if you sit there trying to challenge them and to try and think more positively, what happens is you're keeping that habit going. And you can get into a cycle of yes, but, oh, I may be all right, things may be, but what about? And it just keeps those thoughts going round and round and round. So the sort of more useful strategy, I think, is to learn to disengage from those thoughts, so that when they come to mind, it's a matter of disengaging, moving on, essentially thinking about something else, giving your attention to something else. If there's something you want to think about, you can jot it down and do it in those 20 minutes. Maybe even half an hour if it takes long. If you have the urge to go to Dr. Google, which a lot of people do, put it down, do it in those 20 minutes so that you are controlling the time you think about those. And the thinking time is literally during that time that you determined when you choose to do it. You can jot things down if they come to mind, so you don't have to keep thinking, oh, must remember to do this, oh, mustn't forget to do that. So you've got a list of things to do while you're in that 20 minutes. But for the rest of the time during the day, what you're trying to do is to break the habits of those repetitive, intrusive thoughts. And the way to do that really depends on what works for you. I'm going to tell you what works for me, not because it's any better than anybody else, but these are real examples of stuff that I do to try and manage. So I have a sort of internal dialogue that I go through, particularly at night, when I'm sitting there or lying there and thoughts come to mind. And I used to be very much into my music, and I will sit there and I will try and think of band names, 10 band names beginning with A, 10 beginning with B, 10 beginning with C. It works. It's a good distraction because it's marginally interesting. Despite the fact I must have done it hundreds of times now, I still can't think of, and I defy any of you that is interested in music to easily say 10 band names beginning with Q. But it's a challenge, it's interesting, and it grabs me. And if the thoughts keep coming back, which they do, I refocus, and really focus on that. So something in your head that you can focus on, and it can be anything. It can be thinking about a holiday, it could be planning something you're going to do the next day. The key is to have something that you know you're going to be, that you've planned to think about. And the reason for that is if you get these thoughts coming into your head and you think, oh my God, what can I think about? What can I think of? Oh, by that time it's too late, because the earlier you stop those thoughts going on, the easier it is to disengage from them. If you wait till they've been going for 10 minutes, you're hooked. So what you don't want to do is to get hooked. So as soon as the thoughts come along, focus on something else. Give your attention to some perhaps internal dialogue. The other thing you can do is have an external focus. And so it may be as simple as, listening into a conversation and really engaging with that. If you're watching TV, listen to the dialogue. Don't let it drift over your head, and just ignore it. And one of the things that I often give as an example is reading a book. Often people say, "Oh, I read a book to try and get rid of the worry, and I'd read 3 pages and I had no idea of the plot, but the ideas, the worries kept going." So the key is about focus. It is really focusing hard. So if you read a book as an example, it is literally reading it word for word for word for word for word. You're not reading it for pleasure, although hopefully that comes, but you're reading it to distract, to disengage. If you're listening to a conversation, if you're listening to music, which a lot of people use, listen to the words. Don't just let it go over your head. So the key is that sort of focus, that you're distracting, you're disengaging. The thoughts will come back. Unfortunately, they do. But if they do, disengage, disengage. And the more you do that, even though you may not be totally successful each time, you're chipping away at that habit and you're learning to give your attention away from it. And even if it's not as successful as you would be, it's weakening it, and it does get easier over time. Anonymous has asked about PTSD. Well, PTSD is a bit more than anxiety. It's sort of intrusive memories and flashbacks about a particular event. So things like EMDR, which is the sort of modern treatment for PTSD, is very good for treating PTSD. Not so much for health anxiety, which is often is future oriented. What does this sensation mean? What's going to happen to me, and so forth. But mindfulness is a very good strategy. And I talked about distraction, and in many ways, the real use of distraction and mindfulness can be very similar. Philosophically, they're a mile apart. But the idea of mindfulness is that you disengage from the thoughts by becoming more immersed and more aware of what is going on around you, or how tense you are, or whatever. So it is an attentional process. And key, just like the distraction, it is about the disengaging from those thoughts, not engaging with them, like I said, sort of classic CBT did, but learning to disengage. And if they're there, but you're not going to pay attention. They're just a small part of what is going on, and they're not the focus of your attention, at least. So we've got some written information. We can talk a little bit more about that a little bit later. The other side of the coin is a more acute anxiety. And some people get acutely anxious. They have a sensation, oh, ow, oh, what's going on? Am I having another clot? And often those sensations that are similar to the time when you actually did have a clot can be very difficult to deal with. So I'm going to talk a bit about the sort of panic or anxiety that can go along with those, because in particular for people that have had a pulmonary embolism, but for other people as well, all clots, the sensations that anxiety can trigger can actually mimic those associated with an embolism, and just make things spiral out of control. So just a briefie about what panic is and what anxiety is. So when we get acutely anxious, what we do is we move into what's called fight flight mode. I'm sure many of you will have come across that. The body is preparing for action. And that involves a number of things. First of all, we typically begin to breathe more heavily because we're getting the oxygen in to sort of do that driving. We get tense, and we are essentially preparing for physical action. It's an ancient response that is very deep within us. The problem is that those occur often at times when we can't do something physical. So we're breathing more deeply, we're getting wound up and tense, and actually it's completely inappropriate for the situation we're in. The body's preparing for something that it's not actually dealing with. And the problem is that that preparation, that fight flight process can actually trigger a whole series of symptoms that are actually remarkably like having had a clot, and particularly a pulmonary embolism. So if we start to breathe more deeply, I won't go into the physiology of it, but essentially what we do is, believe it or not, we get too much oxygen into the blood. And that oxygen can set off a whole series of experiences. It can make us feel tingling. It actually makes us feel short of breath, ironically, because it interferes with the brain's control over breathing, and we have to take over our breathing. And so just by that anxious breathing that we do, that can trigger a whole series of symptoms that make us think, oh my God, things really are going bad now. I feel lightheaded, I'm tingling, I've got a chest pain. And actually, all of those are nothing to do with any reoccurrence of a clot. They are simply the beginning of an experience of panic. And so we can sort of spiral off into that acute, pretty awful experience of a panic. There are some very, very, very simple things that can be done. And one of those is, as I said, it's the disordered breathing that actually causes a lot of the experiences that people are having when they're getting panicky. And it drives that, fear of things are really going wrong now. So what can you do? Well, the simple thing is to control your breathing. And I'm now going to show you a little trick that you can do if you like, just to see how you're breathing and what the breathing is. So if you can do what I'm doing, if you can see, put your hand on your chest and your hand on your stomach and just breathe in deeply a few times. Or, okay. I'm not going to ask you, I'm not going to have a hands up and tell us, but there's a simple thing. If when you breathe in deeply, your hand on your chest moves and your hand on your stomach doesn't move, or indeed may go in, that's a sign that you're at risk of this particular breathing process. Because when people begin to hyperventilate, technically, when people begin to breathe more rapidly, they tend to go. And when you see people do that, or when people do that, what's happening is that really is getting all that sort of oxygen excess into the body and causing triggering a lot of those symptoms. So one trick, if people are beginning to feel a bit panicky, a bit of that acute anxiety, is to really just slow the breathing down and to breathe in a way so that as you breathe in, the stomach comes out. And the top hand here, your chest doesn't move at all. And what you're doing when you do that is to bring that a nice slow breathing in that's going to get rid of all those weird stuff that's going on with your oxygen levels and so forth. A lot of the sensations we experience are as simple as that. And there's a nice trick. If you look on the internet, YouTube or whatever, you'll see hundreds of videos called box breathing or breathing the square. And what they do is just talk you through a nice, slow breathing pattern. And it goes something along the lines of breathing in 1, 2, 3, 4. It's like a box. Holding 1, 2, 3, 4. Breathing out 1, 2, 3, 4. Holding in 1, 2, 3, 4. So you've got a nice, slow breathing. And that, if you get it in early enough and you spot what's happening, can be a real way of sort of controlling some of that anxiety. And then it may be about managing some of those worries that you have to think about. Right, I'm going to deal with that. One of the things that people often panic about, and I know Claire has some views on this, so she's had her blood pressure done. It's all been go down there with Claire. But one of the things that often happens is that if people get sensations that they think, oh my goodness me, I'm having another clot, what do I do? Should I go for help? Well, one way of managing that, first of all, is to bring that panic, is to bring that anxiety down by some nice deep breathing. And what Claire will say, some strategies to work out how to work whether you're having a clot, at least DVT, etc. But the critical thing is that if you think about, you are going to have to go to hospital to have this looked at, and that hospital process is literally going to take hours. If you spend 5 or 10 minutes, not assuming that things are going bad physically, but maybe it's just that anxiety that's driving and that panic, and do some simple strategies to calm yourself down, what you may find is that a lot of those symptoms, a lot of those acute sensations sort of disappear, and you no longer feel that need to go to hospital. But that Claire, who's been through this many times, can sort of talk about that. Do you want to talk about it now, Claire? Do you want to give us a...
Yeah, just a disclaimer for anybody who's watching, I am actually in hospital. I am not in hospital permanently, I'm just in for a day case. Unfortunately, this was arranged after the webinar was arranged for today. So I do apologise if it's freaked anyone out. I am actually okay, I'm just getting some treatment and I'll be home hopefully by 2 o'clock today. Yes, and this ties in quite nicely with a question that's being asked on the Q&A, because quite often what we see is, and it is generally around the 3-month mark, and I've been noticing this more and more on our closed group recently. We'll get a lot of people who come about 3 months, they will get twinge in the leg, they'll get pain in the chest, and those pains often are very, very similar to what they had with their very first clot. So the first reaction is, rather than to just sit and take a step back, and 99% of the time it's because they're not told what to expect when they first have the clot, is they panic, I'm having another clot, which then sends everything else into overdrive. And it was a question that was actually asked on the last webinar, which is, how do you know if you're having a clot? And how do you know if you're not, if it's post-thrombotic syndrome or something else? And essentially, you don't know if you're having a clot, but there are a couple of easy ways that you can sort of manage it and take stock of it. Generally, and what the medic said before was, your symptoms will always be persistent if you are having another clot. So if you take 10 minutes to do some breathing exercises and that chest pain massively subsides and your breathing goes all right, 99% of the times you're not having another clot. It's just been some little bits of anxiety that are creeping up. If we're pains in the leg or a rapid swelling of the leg, all of a sudden that you've not noticed previously since you've had the clot, and you notice, oh, my swelling's just gone down, ask yourself a couple of questions first. Have I been doing more than I've done since I've actually had the clot? Because the chances are, if you have, you've probably just overdone it a little bit. And if you get that leg raised over about 12 hours and that leg swelling comes down, again, the chances are it's not a clot. Obviously, if you are panicking and if you are unsure, you can always go and get checked out. And sometimes there are people that literally need to do this. And then after about 9 or 10 times of sitting in A&E and then being told, no, it's not another clot. No, you're fine. It's just your leg. They soon start to develop a sense of what is a clot and what isn't. And sometimes you do have to go through that process in order to understand what your body is doing. The reason why you tend to see it more at the 3-month mark is because that is when everybody will tend to start doing a little bit more, because generally your symptoms have subsided and you think, oh great, I'm getting better, so I can go out and do this, I can go out and do that. And then all of a sudden you do get knocked back with this, oh God, I've got a chest pain, or oh, I've got leg pain. And then that sets everyone right back. And you can generally see a pattern of it going through our closed group. as a patient, and it should be reassuring that you do see these people and that they do go and get checked out and they don't actually have clots. So look at that as well. But again, if ever you're unsure, always go and get checked out, and that is the best advice we can give you. You know, there's no easy, quick or fast rules with any of this. Paul's breathing exercises are really good, especially if you've had PE in the past. And raising that leg is the best way to see whether your clot is a new clot or whether it's a little bit of post-thrombotic problems, because that swelling will go down if it is post-thrombotic. Does that cover it, Paul? You're on mute.
You had that little trick of putting your leg up or something for...
Yes.
Have you mentioned that?
Yes.
Oh, I was falling asleep. You were so exciting. Sorry, I was answering.
Do you want me to fly over to Mallorca?
No, to be fair, I was answering one of the comments as that sounds good to me. I've got it. There's another one from Zainab now. Zainab Ali. How does deal with constant rumination that leads to inaction? That's a really interesting and problematic issue, because you're right. If you can just feel overwhelmed by what do I do, what do I do, what must I do, what can I do, what's going on. But I think that I mean, it's both a simple and a difficult thing in a way. But I think the key to that is to do all the things that I was talking about. But when you are doing that 20 minutes sort of thinking through, literally get an action plan and, decide what you need to do and make a plan, not just, oh, I'm going to talk to the doctor, but a more specific plan. I will contact the doctor, I will contact my GP, I will arrange so that you're getting some sort of concrete plan of what action you want to take during that. And the more specific that can be, the more likely you are to do it. It's not just, oh, I'll contact the doctor about this. It's on Tuesday morning, tomorrow morning, 8 o'clock, I will contact the doctor. Once we make specific plans, we're not guaranteed to do them by any means, but we're more likely to do them than if we just have a vague, oh, I'll contact the doctor, or, oh, I must remember to talk about that. Get them written down so that you've got some sort of strategies, some issues. If you want to talk over things with the GP or hematologist or whatever, and you've got some questions, literally write those questions down so that when you go into the hematologist or the GP, you're well prepared. You've got all those things down, and you say, I want to know about A, B, and C. And that is really useful for you, but it's also really useful for the hematologist, because, if you go in there and you say, I want to talk about this, this, and this, they can judge what they're going to say to you, how long they're going to take, etc., etc. So being prepared for those sort of meetings with people that have information that's relevant to you, really important. So yeah, write it down, get it down as specifically as you can. It sounds, but actually, it actually does make such a difference. So I'd go for that. We're running out of questions. Any more questions? Oh my word, 174 participants and 3 questions. Any more out there?
I have a question.
Oh, you always do, just to rescue.
We've shared links to where anybody can go and download medically approved information to support coping with panic or sleeplessness, all sorts of things around the impact of blood clots. But some of this I know we've had in earlier sessions. Sometimes it's really difficult for those who are trying to manage patients to also understand the best way of doing it, especially if they're not specialists in the area, or if they haven't had the training such as you've had, Paul, or some others have had. Are there any resources available where healthcare professionals with an interest in this think, I'd just like to read, I'd just like to gather more, so that I can do the best I can in trying to support individuals when they come into my care to reduce that anxiety before it perhaps takes off sometimes.
Yeah, I mean on our actual website we've got some leaflets that are when we first did those, they were pretty brief. You know, do this, do if you have this, do that. If you have the other, do t'other or whatever. And you know, they really were getting to the core of the things that will benefit people. So you know, they're good to read anyway. But what we've done more recently is produce some more in-depth leaflets. So these talk about some of the underlying processes. Because I mean, I for one, you know, it's useful to know what to do, but I like to know why I'm doing it, what's going on. And so those leaflets, there are some more in-depth things that are, you know, really easy to access. And they include a little bit of the sort of background, the physiology, the psychology of what's going on, and then a little bit more detail about how to sort of manage the issues. And so for people that don't really want to plow a book or whatever, because frankly, who's got the time if it's not your area of sort of necessity expertise? But yeah, just download some of those more in depth, and they really talk about. We've done one for sleep, we've done one for um, you know, panic, and a lot more about the mechanisms and not just the breathing, but some additional strategies people can use to help them manage panic, and about the rumination. So those key things. There is there's some information out there that people can get a bit more depth without hopefully being overwhelmed. And to be blunt, I wrote them. So if people are interested and read them and think, oh, that wasn't too good, or oh, that was marvelous, I'd be happy for some feedback. So we can go a two-way process here. But yeah, they're available on the web, the links that Joe's given. And if you go to the leaflet, there are sort of they're a little bit interposed. There's no in-depth ones and simple ones. They're a little bit, but the ones that are more in-depth are sort of called deep dives. So if there's a leaflet there called a deep dive, it's more a few pages of A4 than a leaflet, but hopefully not overwhelming.
Thank you. The other thing I wondered about, are there apps that can, or that maybe from the NHS or other reliable sources, which can sometimes help support the therapies that you've gone through today?
Yeah, I mean, if you go onto, I mean, there are some definite apps. I mean, somebody's already taught us one about here about Headspace, or there are lots of mindfulness apps, and they can be incredibly useful. And a lot of them, I'm not going to advertise, but you know, if you just type in mindfulness app, you'll come across them all. A lot of them do sort of free introductory stuff. Most of them you end up paying if you want the in-depth stuff. And I think they are really very useful. Some of the CBT stuff, the breathing I was talking about, I mean, there's literally dozens, if not hundreds, of YouTube videos about those sorts of things. I think the thing to bear in mind from what I've been talking about, and I did sort of hint at this earlier, I'll talk a little bit more about it, is that there is the simple distraction that I was talking about, and mindfulness, although in many ways they're very, very similar, philosophically they're very different. And the mindfulness apps usually take a degree of effort to get used to using the strategies, to sort of getting the benefits of them. In my opinion, that is time well spent, but the distraction is probably a good first off process, using distraction and disengagement. If you actually then go on to the mindfulness, you'll probably find that they seem very similar. They're all about disengaging from the thoughts and focusing elsewhere. So to a user, they may not feel that different, although historically they are quite different, to be fair, in terms of their philosophy. So yeah, the apps are brilliant. I'd certainly go for them. And if I see people individually, I do recommend those as a sort of adjunct to what we're doing, because they can do it better than I can.
How about when things get quite severe, either as an individual or trying to, as a healthcare professional, manage those? Are there things like is it talking heads or anything like that? Because I know there's so many waiting lists to refer people through, but are there other ways that people can be referred or seek referral for psychological support?
Oh yeah. Yes, go to your GP and say, I need some support. Yeah, I need to be cautious here, because the IAPT program in England, or what did you say it was? Talking, I can't remember what it's called now.
Talking heads, I'm not certain, but I think the
Yeah.
IAPS one.
They do have a sort of route for people with chronic physical problems. So definitely worth talking about if you're in England. I'm not just in Mallorca all the time. I live in Wales, and we don't have that in Wales, so it is a bit geographically limited. But yes, by all means, go to your GP and do that. Sorry, I've got a question from M. Shaw, very formal, M. Shaw. Getting back to work, dealing with lots of questions. Um,
Do you want me to answer this one, Paul?
I've got some ideas, but I'd welcome your ideas, and then I'll tell you whether you're right or wrong.
Firstly, well-meaning people telling you look well, just say thanks. I've actually been quite severely ill, and just leave it at that. People will always be well-meaning. I think there's a sort of tendency in the UK to want people to look ill or look disabled in order to justify a diagnosis. My mum's always brought me up to never look bad in public, never look ill in public, and just generally not look ill at all. And over the past 21 years, I've been quite severely ill. Last time I was in hospital a couple of weeks ago, I actually took my straighteners in, was working on the ward, and did my hair every day, and I did look quite well, although I was not very well at the time. And it's hard. People will always want you to look well to justify a diagnosis, and a lot of the time that's more their issue than it is yours. So just thank them and tell them, great, that makes me feel better. Thanks for saying I look so well, and just move on. If people can't accept the diagnosis, then that's their issue. You don't have to appease them by doing anything else. And that's the way, politically correctly, I would answer it. There is another way I would tell them, if they did persist, but I can't possibly say that on a webinar. Jenna wouldn't let me.
Yeah, I mean, I certainly aren't going to say that was, she's back. Come back, Claire. I think it's an interesting one, because I to sort of slightly move away. But I think one of the problems that people do face is actually well-meaning family, is well-meaning friends that say, how are you? And every time you see them, they go, how are you? And that it can be overwhelming, but B, if you're trying to disengage from thoughts about how you are, that can be really challenged, because you're just getting all those prompts to think and talk. And in some ways, I think it can be, what I have done with people is suggest, and people have found this useful, it's not just me, if people are doing that, to say, I've been really bad, but say, look, I don't want to talk about it because it just brings back memories, that make me feel anxious, or that make memories that I don't really want to go through. So can we just move on and disregard? And for friends and family in particular, it's like, it's not as, I know you're saying, how are you? because you want to show your care and your love and your affection for me. But actually, at the moment, it may actually be quite helpful if you don't say, how are you? If there's things I want to tell you, just let me bring them up. But don't you sort of keep asking how I am, because it just makes me go over things that actually I find uncomfortable dealing with. And most people quite happy talking to family about how they feel, but if people have all these intrusive worries and thoughts that they're having difficulty managing, and every time, a family member asks how you are, it just keeps it going. And some people find that quite overwhelming. So just a quiet chat with family and friends and say, look, I've had a bad time, but I really don't want to think about it at the moment. So let's, it's a sign of your caring for me that ironically you don't ask how I am. I'll tell you if I need to.
Paul, just to add on to that as well, there's no harm in before you going back to work. If you don't want to talk about this or you don't want people to ask you questions, just mention it to your employer. My daughter she's away in college at the moment, and there's been someone who's had quite a traumatic family experience, and the first thing they've said to all the pupils before she comes back is she doesn't want to talk about it, she doesn't want it mentioned, please don't discuss it with her unless she discusses it with you. And people can abide by that, and people can sort of deal with that, and they deal with that then before you come back in. Because I don't know why people want to see you literally struggling to breathe, or dragging a leg round or on crutches to justify a diagnosis. It baffles me. It's almost like you've got to act the part, when I never have done. I've walked into A&E before now in a pair of stilettos and said, I think I'm having a clot. And they look at me as if to say, no, you're not. And I just go, look at my records. And then they go, oh, yeah, you probably are. And then they still stick me in minors because I look well. And even a consultant said to me, my worst issue is that I don't look anywhere near as ill as I actually am. But that's not to say that I need to make myself look as ill as I actually am in order to justify what other people want to see. You just need to sort of manage it and let people deal with their own opinions and impressions. If they can't accept you for who you are, or what you look like, or what you are, then they're not really worth knowing or bothering with. And that's my opinion on the matter. Probably different to Paul's.
Perfect. Unmute. No, that sounds perfect. I'm going to stay quiet on that. I'm just looking at, there's a hematologist said, and I know you've replied, Claire, but I'm going to sort of do a public, public as well as a written thing, because I think it's really quite interesting that if you look at the sort of communication issues between doctors and patients, nurses and patients, physios, whatever, healthcare professionals and patients, they have you often find there are different agendas that, the sort of clinician of all types wants to talk about treatment, diagnosis, get people taking the right medication. And the patient wants to talk about anything else, but, what about this? What do I do about this? What do I do about the other? And I think Claire's sort of got it right in her reply, in the written reply, but there's quite a lot of evidence that you get a lot more satisfaction and a lot more adherence to medication. People walking out feeling much less anxious if you have that conversation that includes some of their concerns or issues. And interestingly enough, even if you don't necessarily have the answers, the research, I'm going into research now rather than personal experience, but research says that actually patients will be less anxious, because they've been listened to and treated in a sort of way that makes them feel, part of that process. So yes, there are some standard psychological, referral routes. And if people are really anxious, then maybe this isn't going to be the answer. But for many people, actually, just that few minutes of engagement with the clinician, the healthcare professional, can actually make quite a difference. And you may have the answers.
Hello. I've just seen a comment that Lisa's made on the webinar chat regards to that you don't present your pain in a way that is normal. So GPs and medical people often think that you're not in pain and move you on. And basically with regards to this, what you've got to sort of do is you've really got to advocate for yourself and just tell them that you don't present in the way that is classical. That is a sort of language that they tend to understand, and just insist that they take you seriously. It's quite difficult to do this sometimes, but you just have to tell them to look at your medical records, and also, just insist. Say, you might deal with a cut finger one way, I deal with it another way. And eventually you will get someone who'll listen. And if somebody's not listening, just has to be referred to the person that's above them until somebody does listen. Because I don't present classically in any way, shape or form with a DVT or a PA. And I just let them go through the motions. And then when the diagnosis comes, then I go back to that person, show them the diagnosis, and then they learn. It's very easy to just feel a bit downtrodden, especially in the early days. And then, you don't advocate for yourself, but it's so important to do that. Paul, I don't know whether you've got any suggestions on that.
Yeah, I think it's interesting because, well, I hate to say interesting. I always say it's interesting, which means it's a problem. But this notion of having your symptoms not being taken seriously by the person that you're attending, the clinician of all sorts, is a real issue. And how you manage that, I honestly don't know. One of the things that I think is problematic is that because the clinician doesn't understand what's going on, it sort of leads you necessarily to be a bit more dramatic and sort of really emphasizing what's going on. And then you get, oh, they're just being hysterical, they're just being psychological. I mean, I've heard so many people present with pain and being told, oh, it's psychological. It isn't psychological. Pain is pain, and there is generally a physical cause. But I suppose in the context of what it's about almost having your patter ready. I've been before. This is what the doctor said, so that you've got a coherent story to tell the clinician that you're working with, in a way to have to prove that the pain is real or whatever, and that there's a past history, and they really should take notice of that. And like Claire says, if they don't engage with that, then you have the right to be seen by someone else. But I think, getting that story, getting that history, I have been here 3 times before, and on each time they have found that I have had, can be a good way of reinforcing the fact that you know what's going on. You are in the jargon, the expert patient, and that this isn't some, psychological thing that is going on and it is real, etc. So I don't know what you think of that, Claire, but it's something that often people come up with.
Yeah, there's always got to be that relationship between the patient and the medic, and if that relationship is not there, there is no harm in, as a patient, saying, listen, this isn't working, I need to see somebody else. you could be as blunt as I do sometimes. And if I see somebody I don't like, I just say to them, I don't like you, I want to see someone else. Because you are not going to get any further. You are not going to get any way forward. And they are not going to get any respect from you or any adherence to what they want you to do if that relationship isn't there. And it's difficult, it's hard, especially if you're new to this, because a lot of people, before you have a blood clot or before you become medically ill, they don't know. You don't get a guide on how to deal with the NHS, how to deal with doctors, how to deal with medical difficulties. You just sort of get told, this is what's happening. And you need to deal with it. And it takes time, but it also takes a lot of guts to turn around to somebody and say, this isn't happening, I'm not putting up with this, this isn't suiting me, and it's not making me feel any better. So if you ever need any help over how to navigate, how to get guidance, how to go round, what doctors you need to see, please feel free to message us. We can always point you in the right direction, and tell you what services close by you there are, who you may need to see. And we can help alleviate sometimes a lot of that anxiety before you even need CBT. And we're quite good at doing that. I've got a lot of patients who I've helped in that way, and Paul often passes patients over to me so I can help them in that way. But it's just, you know, if you went into a shop and somebody didn't serve you properly, you'd have no hesitation in saying, can I speak to the manager, please? Exactly the same in a hospital or a doctor's. Just because it's a doctor or a nurse doesn't mean you cannot say that.
I think the problem is, and I know time's rushing, which is why I'm sort of rushing into this, but if you look, the evidence suggests that the doctors and the nurses and the physios, sorry, I say doctors because you often talk about, apologize. The people that think they are the best communicators often turn out to be the worst communicators. And the people that think, oh, I'm not a great communicator, actually care about it and tend to be the better communicators. So, you know, if somebody really isn't communicating well, and you really feel that you are, you know, things are not going and you are not getting through to this person, you know, arguably, however hard you try, they think they're doing a good job and you think you're not getting through. So maybe the answer, as Claire has said, is to say, look, this is difficult for me. Is there anyone else, or follow the process that Claire would advise? Because, you know, people, I'm sure I'm the same. I'm not saying it's just, you know, I think I'm magnificent, so many things, and my wife tells me I'm not. So, you know, we all have these misperceptions, but, you know, some people may feel they're doing a really good job at communicating with you, and you're really thinking, no, this is not really working for me. But they may not have that insight because they have that different agenda they're following and they think they're doing it well. So to say, could I speak to somebody else? You know, I'm still a bit concerned. Is there anybody else? I think that's, you know, perfectly reasonable. And, you know, you don't want to keep battering your head against a brick wall all the time. It may be better to talk to somebody else than to keep trying to get through to that one person that you're struggling with. But this is a system thing, not an individual thing, to be fair. And Claire's much better at that than I.
Thank you both so much. I know we've run out of time. It's been a really good session.